Hello and welcome. I'm Dr. Eric Yonash. On behalf of Creative Educational Concepts, thank you for joining us in today's educational activity, which is entitled Identification and Surveillance of Individuals with von Hippel-Lindau Disease. Today's activity is supported through an independent educational grant from Merck and Company, Rahway, New Jersey, USA. This activity may include discussion of products or devices that are not currently labeled for use by the US FDA. So I'm Dr. Eric Yonash. I'm professor in the Department of Genitourinary and Medical Oncology at University of Texas Medical Center in Houston, Texas, and I've been treating individuals with von Hippel-Lindau disease for over 20 years. The learning objectives for today's talk include evaluating current surveillance approaches for the identification of von Hippel-Lindau disease, and second, to engage an interdisciplinary team of professionals for the care of patients with VHL disease or VHL-associated tumors. So here's an overview of VHL disease. This is a rare autosomal dominant hereditary syndrome. It affects 1 in 35 to 40,000 individuals at any time and accounts for approximately 1 to 2% of renal cell carcinoma cases. It's caused by a pathogenic variant in the VHL tumor suppressor gene, which is located on chromosome 3p25. And loss of functional VHL results in dysregulation of hypoxia-inducible factors, which results in increased angiogenesis, proliferation, and tumor growth. Of individuals with VHL disease, we can see that there is heredity in 80% of these individuals, but 20% can be de novo variants. And we do see near complete penetrance by the age of 65. In terms of clinical presentations, we have several key areas that they will develop disease manifestations. These include CNS hemangioblastomas, endolymphatic sac tumors, and pancreatic lesions. And of these, the CNS hemangioblastomas are probably the most common, and the endolymphatic sac tumors probably the least common. And in terms of the manifestations that we would see, for example, the CNS hemangioblastomas, it could, as these grow larger, result in neurological deficits. The endolymphatic sac tumors may result in sudden hearing loss. And the pancreatic lesions themselves may not cause symptoms unless the cystic lesions that develop in the pancreas are sufficiently large to perhaps cause GI discomfort. Other lesions that we can see are pheochromocytomas and paragangliomas, and these may be asymptomatic or symptomatic. Renal cell carcinomas, which will be multifocal in the majority of individuals and are also associated with renal cysts, and renal retinal hemangioblastomas, which can occur, again, in a relatively small percentage of the total population, but can be devastating with loss of vision. Of all of these lesions, 2 of them are bona fide cancers, the renal cell carcinomas that I mentioned, and also in the previous slide, the pancreatic neuroendocrine tumors that can arise in the pancreas can be bona fide cancers, and both of these require close surveillance, and if they exceed 3 centimeters in size, may have metastatic potential, requiring close follow-up, and we'll talk about that more later. Let's start with this case of Michael. He's a 22-year-old college student with a family history of VHL disease. His mother was diagnosed in her 30s after developing renal cysts and a cerebellar hemangioblastoma, and genetic testing identified a pathogenic VHL variant. Her diagnosis prompted discussion of genetic testing for other families, including Michael. So the question really here is, who should be tested? In this situation here, we have an individual whose first-degree relative has confirmed VHL. And here we may already know what the familial variant is, and if that's the case, you can do very specific testing for that particular variant. And if the proband themselves is unavailable, if there are other family members, you'd want to test those affected relatives, and that will also give you a lead-in into how to test Michael. We do know that because this is an autosomal dominant inheritance, that 50% of children will statistically develop VHL disease, or more precisely, there's a 50% risk of each child being saddled with this germline mutation. Because of the spectrum of disease manifestations, early molecular diagnosis is really helpful for these patients. It directs surveillance, guides family counseling, and identifies candidates for specific therapies. So, question here, which of the following patients should be referred for genetic testing for VHL disease? Well, the answer in this case is D. 29-year-old patient with bilateral retinal hemangioblastomas really is the individual that you'd want to test here. And the reason for that is because these are VHL-specific manifestations. It's very unusual to see bilateral hemangioblastomas. And when you do see these types of manifestations, it makes you want to think about these particular things that you want to rule out. So, next question here is, what age do you typically initiate genetic testing in individuals at 50% risk? And I think that really depends on the penetrance of the particular syndrome that you're looking at, and whether or not knowing earlier will inform how you manage these individuals. So for VHL disease, we know, for example, the retinal hemangioblastomas can manifest very early in age, even at 1 year or younger. And the pheochromocytomas can occur before the age of 5. And so for that reason, you really want to do germline genetic testing to rule out VHL as early as possible. Some of the other challenges here are cascade testing like this can really potentially be burdensome to family members, can cost money that they may not have, and finding ways to make this easier for family members is going to be extremely important. So here we now have a 22-year-old patient who presents with a family history of VHL disease, and they have a 1.8 centimeter enhancing right renal lesion. Which would be the most appropriate initial genetic testing approach? So here are the current genetic testing strategies. We can do single gene testing, and in the case of our patient here, this would make a lot of sense because we know there's a familial antecedent. We would likely be able to find out what the actual mutation is. So you can actually do a very specific testing for this particular individual to confirm the presence or absence of that familial germline mutation. Multi-gene panels can be useful when you're thinking about a particular syndrome. So you have an individual who's maybe younger, who has renal cell carcinoma and a family history of renal cell carcinoma, but doesn't exactly fit a particular syndrome. Here, you can look at a panel of genes that may actually be associated with hereditary renal cell carcinoma. And examples here are things like, for example, STH gene, FH genes, folliculin, RET, and others. Comprehensive genetic testing really is when you have a negative VHL test, for example, but there's a suspicion for VHL disease. And maybe here you might be able to identify different variants, low-level mosaicism, etc. So here, this is a bit more of an unusual and niche situation, and one that might be applied in a subset of patients. So what is mosaicism testing? If you do see clinical features of VHL, but blood testing is negative, you might need deep coverage sequencing or multi-tissue analysis. And this will be typically for an individual who's first in family where perhaps, for example, the hematologic hematopoietic system doesn't actually have the mutation, but other parts of the body do. So in terms of a testing approach and follow-up here, if you see typical VHL features, you'll start with a single gene VHL sequencing and then perform a deletion duplication analysis. If you have atypical or isolated renal cell carcinomas, maybe consider a broader renal cancer panel. If you have a negative, inconclusive result with persistent suspicion, here you would move into mosaicism testing. If no variants are identified but strong family history or relatives are untested, here, we see this sometimes. So you you have your proband, you've got a number of other individuals who clearly have some sort of a syndrome, but you just can't identify it genetically. What do you do here? I do have several patients like this, and I do follow them with a sort of VHL-esque panel of imaging studies just to make sure that I can follow the lesions that we already know about and rule out the presence and development of others that may be associated with the syndrome. And obviously, if the variant is confirmed here, and you have other potential family members that are susceptible, you want to extend cascade testing to individual relatives. Here we have a patient with clinical features suggestive of VHL that undergoes initial germline VHL testing, and it's negative. What would the next most appropriate diagnostic step be? Here, if you have a syndromic pattern in the individual, which really, for example, you have retinal spinal hemangioblastomas, you have renal cell carcinomas, you have pancreatic lesions, but you have a negative test. I think the most appropriate thing here really would be to do mosaicism testing, to do deep coverage or multi-tissue analysis. And this would be specifically if you don't have a family history and you're thinking this might be a first in family individual with mosaicism. That would probably be the most appropriate next step here. So back to Michael here. Because a familial VHL variant has been identified, Michael undergoes single gene VHL sequencing with deletion duplication analysis at age 6. It's a little late in my mind. I would say that ideally he should have been tested earlier, but testing confirms that he carries the same pathogenic variant as his mother. He's now being monitored through routine follow-up for individuals with VHL, with management coordinated across specialties. So, which of the following best describes renal surveillance recommendations for patients with VHL? So the answer here really is abdominal MRI every 2 years, beginning at age 15. Once again, as I mentioned, based on our understanding of when these manifestations will occur the earliest in our observed follow-up of patients with VHL disease, will likely prevent you being surprised with a larger tumor that could be threatening for the individual. Ultrasounds were something that were recommended in the past. They're just not sensitive enough. Maybe microbubble contrast ultrasounds, but the MRI does not have radiation. It provides the sensitivity and specificity you need. And obviously, MRI starting at the age of 30 is too late. All patients with VHL disease, including those who are asymptomatic, should initiate lifelong surveillance for associated tumors. And as mentioned before, retinal hemangioblastomas can occur before the age of 1, and dilated retinal exam every 6 to 12 months beginning before age 1 is appropriate. CNS hemangioblastomas, these typically will start developing in the teenage years, and we're recommending MRI of the brain and spine every 2 years beginning at the age of 11. If the test is negative, you don't have to do it every year. If you start seeing lesions, the frequency of imaging should likely be increased to annually, or even more frequent if they're faster growing. Renal cell carcinomas, they start occurring in later teenage years, and the recommendations that we now have are that the MRI of the abdomen be performed every 2 years starting at the age of 15. And these recommendations are basically designed to prevent us missing any major manifestation from patients and start a little bit earlier than the most early case that we have seen with any of these organ system manifestations. Pancreatic neuroendocrine tumors and cysts, the MRI that you're performing for the kidneys will cover this as well. Pheos and paragangliomas, blood pressure and pulse every 2 years starting at the age of 2, every year starting at the age of 2 is appropriate. And plasma and 24-hour urine metanephrines starting every year beginning at the age of 5 are recommended here. And for endolymphatic sac tumors, relatively rare, but potentially devastating, so you want to be able to identify these early. Audiology evaluation every 2 years beginning at age 11 should be done. And then when you're doing the MRI of the brain at age 15, you would want to make sure that you have fine cuts through the auditory canals. Most MRIs that are being done now are probably sufficiently sensitive to be able to sort of cover those on their own. So when you do start performing surveillance for children with confirmed VHL, which organ systems do you prioritize first? As we talked about, we really want to make sure the eyes and the pancreatic, the pheochromocytomas are picked up early, because these can really be problematic for individuals. Obviously, visual changes that could be addressed, or prevention of visual changes by lasering retinal hemangioblastomas early on, and the physiological effects of an active pheochromocytoma. And what are the biggest challenges in maintaining lifelong VHL surveillances? And how can we improve patient adherence and coordination across specialties? Having done this now for more than 20 years, I think this is burdensome for patients. And what is best is to be able to create a system that is as easy as for patients to follow, that if you can provide reminders for patients, set things up for the patients in a way that it takes as little time as possible, get the scans organized in a way that they don't have to come back for multiple days, make sure that they don't have to see all the specialists whenever they come back. In our practice, I end up being the coordinator for all of these images. I review the images. If there are any areas of concern that are subspecialty specific, then I will ad hoc speak with my specialty colleagues. And this way, the patient doesn't have to run physically from person to person and building to building. And it makes the whole experience less traumatic, and it's more likely that they will comply. Of course, there are some exceptions here. I'm not an ophthalmologist, so that really needs to be done by the subject matter expert. And so that will be additional visits for the patient. But other things like the routine imaging can be coordinated in a way that makes it less onerous. So at age 22, Michael's surveillance MRI reveals a new 1.8 centimeter enhancing right renal lesion. He's asymptomatic from this and has normal renal function. And a discussion ensues on whether or not to observe or to initiate treatment. So interdisciplinary care is obviously very important here. So we have a number of stakeholders, obviously the patient themselves, the patient family members. We have a genetic counselor that's really important in the initial diagnosis and counseling additional patient family members, reflex testing. We have the urologist / nephrologist in really managing kidney health. We have the primary clinician that's involved in the patient's care, the cheerleader in chief and nurse navigator, to really make sure that long-term follow-up is adhered to. The audiology and making sure that we're not missing endolymphatic sac tumors. If there are hemangioblastomas, neurosurgeon, neurology, I would say that in most cases what we're dealing with here are neurosurgeons who are capable of appropriately intervening and identifying when interventions should occur, whether they be with systemic therapy or with neurosurgical intervention. And the ophthalmologist, who really obviously has to be the person in charge of monitoring the retina. We have local therapies and surgery that had been the mainstay of treatment for individuals with VHL disease for the longest time. For retinal, the laser ablation of lesions is very important, and we want to prevent the life-threatening visual loss. The pancreas, the cysts can often be quiet, but if you have pancreatic neuroendocrine tumors, we need to make sure that those do not exceed 2 to 3 centimeters in size, where they start developing metastatic potential. Renal cell carcinomas, the cysts usually are not a problem. We don't end up getting like polycystic kidney disease. We don't end up getting decline of renal function to the degree that we would with, for example, polycystic kidney disease. But the renal lesions themselves, if they exceed 3 centimeters, have metastatic potential. We have to watch those closely and intervene appropriately. And the pheochromocytomas, if they're biochemically active, they can be problematic. And the CNS hemangioblastomas oftentimes are asymptomatic, but at a certain point in time, especially if they develop a cystic component, they can be really life-altering and very morbid, and close follow-up is required for them as well. So, as alluded to earlier in this presentation, loss of VHL. VHL is an E3 ubiquitin ligase that regulates hypoxia-inducible factors 1 alpha and 2 alpha. It looks like HIF2 alpha is one of the major oncologic drivers here. And if you have unbridled HIF, you end up getting transcription of HIF client genes that result in a number of untoward manifestations. HIF2 alpha heterodimerizes with HIF1 beta. And if you can prevent that heterodimerization, you will prevent that inappropriate transcription. And there are drugs that have been, there is a drug that has been approved for VHL disease, belzutifan, that is capable of downregulating this by binding to HIF2 alpha and preventing HIF1 beta 2 alpha interaction. And this drug, belzutifan, was FDA approved in 2021 for VHL-associated renal cell carcinomas, CNS hemangioblastomas, and pancreatic neuroendocrine tumors not requiring immediate surgery. The similar drug, belzutifan, was approved for advanced renal cell carcinoma after PD-1 and VEGF TKI therapy, and was also approved earlier this year for adult and pediatric patients over age 12 with advanced pheochromocytomas and paragangliomas. Other agents that exist in the same sort of family include NKT2152 and casdatifan. And so this is a class of agents now that are being developed, and it's going to be very interesting to see how this class develops. So LIGHTSPARK-004 was the study that tested belzutifan for patients with VHL-associated renal cell carcinoma and other neoplasms. Eligibility required at least 1 centimeter large renal cell carcinoma, but they could have any of the other lesions, and most of them did. And what we saw with 50-month follow-up is a 67% objective response rate in the renal cell carcinomas, 11% CR, no progressors, upfront progressors as best response. In hemangioblastomas with 38-month follow-up, 44% objective response rate, 8% CR, and I believe one individual who had progressive disease as best response. And the pancreatic neuroendocrine tumors, a rather amazing 91% objective response rate. So the FDA approved this for these 3 different lesion organ manifestations due to the robustness of the data. In VHL disease-associated CNS hemangioblastomas, saw that if you looked at just the solid component and not the solid and cystic, there you saw a 76% objective response rate. So even higher than what we see with the cystic component, but we're seeing that the cystic component can also decrease in size with this therapy. Belzutifan was tested in advanced renal cell carcinoma, and we saw that compared to everolimus, there was an improvement in progression-free survival and a trend towards overall survival. In LIGHTSPARK-15, belzutifan was tested in individuals with advanced pheochromocytomas and paragangliomas. And this study looked at 72 patients. It showed an objective response rate of 26%, a median duration of response of 20.4 months, and individuals had a reduction in hypertensive medication use, demonstrating the physiological effects of this therapy. So which of the following any grade adverse events was most commonly reported with belzutifan in patients with in the LIGHTSPARK-004 trial? In terms of safety, the most common side effects we see are anemia, fatigue, and dizziness. And so the fatigue is something that we're likely seeing because of the effects on hemoglobin. it's also because of the anemia as well as anemia independent. And you can see some of the other less common side effects here. So in our case here, this 22-year-old individual with a renal mass, he does begin treatment with belzutifan to delay surgical intervention. And this is a choice that some patients may make. A couple of things about this case, though. This lesion is less than 2 centimeters in size. It's growing, but it has not reached 3 centimeters. So continued observation would still be reasonable and safe. If you have an individual who has a solitary lesion and no other organ system manifestations, an intervention at this point in time, like a partial nephrectomy or an ablation, is also a reasonable choice. And this is where shared decision-making comes in. And having that conversation with the patient, providing them with the options, continued observation, some sort of an ablative or surgical intervention, initiating belzutifan, I think are all reasonable choices. And you really need to get the patient's input on what they want to do here. And in this case, this patient started belzutifan. The therapy was well tolerated. They experienced mild fatigue and transient anemia. And after 6 months, MRI showed reduction in the size of the renal lesion, stability of pancreatic cysts, no new lesions, and the patient elected to continue belzutifan with ongoing surveillance. What strategies have you found to be effective for managing belzutifan-associated anemia or fatigue while maintaining quality of life? I, for one, and this is not on label, but I think most individuals who treat VHL patients manage the anemia with ESAs. There are other ways to approach this. You can dose reduce, you can dose hold, you could transfuse. I think a lot of these are up to the individual provider as well as to what the patient's preferences are. And how do we see the management of VHL evolving over the next decade? I think some of the questions here really are we going to be using belzutifan continuously? Are we going to start using this drug intermittently in some of the patients? We don't have any evidence at this point in time that that type of approach is appropriate, but these are the sorts of research questions that are likely going to be posed and potentially answered. And the next question really is, how long can we keep people on belzutifan? The longest patient I've treated now has been on for more than 8 years. But is this something that we can continue for 10, 15, 20 years? At this point in time, we don't know. Next question is, this is a good drug, but are there better agents that can be applied to this patient population? And the answer is hopefully. And we really need to, I think, continue our research and our understanding of the disease to better serve our patients. So SMART goals allow us to put information into action. First of all, increase appropriate genetic testing for individuals, coordinate structured lifelong surveillance that's not too onerous on patients, enhance multidisciplinary collaboration. If you're treating these individuals, make sure you have a team of individuals who have subject matter expertise and find a way to make that team work in harmony. And provide timely intervention. If we do have a patient who has lesions that require intervention, let's make sure they're taken care of appropriately. So I will end here. Just a reminder, there are other activities in this series, and we will be talking about diagnosis and multidisciplinary care of VHL-associated tumors in a future version of CEC Briefcase. For additional resources, you can look at this webpage. And to request and collect credit, participants must complete the post-test and evaluation online. And remember to click on the Request Credit tab to complete the process and print your certificate. Thank you very much. Hopefully this was helpful. And